information with us. I started recording. Ruben, I'll turn it over to you.
Great, thank you very much. All right, can everyone see my slides okay?
Yes, we can.
Great. Well, thank you very much, Gina. My name is Ruben Wilson. I'm the head of the Alternative Crisis Response Unit at the Department of Mental Health. And so today, as part of our Alternative Crisis Response System, what I'd like to do is spend today giving you a presentation on best practices for coordination of law enforcement and mental health in alternative crisis response. Over the last year and a half, we've been putting together a best practices guide for how mental health and law enforcement can coordinate in the field effectively, towards the objectives of alternative crisis response. And so I wanted to give you all an overview of that, and provide you with a copy of that report as well. So as you know, the alternative crisis response programs, the aspiration is to ensure that if individuals in the community are experiencing a behavioral health crisis, that we can treat those individuals within the mental health care system, so that they can remain in their community as an alternative to law enforcement involvement. Our goal is really to minimize the role of law enforcement in responding to incidents involving persons experiencing a behavioral health crisis as much as possible, where we can send an unarmed civilian response team of mental health professionals. That's far more preferable than a law enforcement response. And we have done this by developing a continuum of care so that we're ensuring that everywhere throughout the continuum of care for individuals who are in crisis, we're making sure that we've got a system that can effectively treat them. And so we want to make sure that we've got a 24/7 alternative for those individuals. It begins with having someone to call, and that's our 988 and our DMH helpline. These are both entry points to crisis care for individuals countywide. It's also having someone to respond, and that's our field intervention teams, which are now operating 24/7 everywhere in the county. Somewhere to go, once an individual needs a higher level of care, we want to make sure that there are sufficient hospital beds available for them, and importantly, that there are alternatives to hospitalization. If someone doesn't need a hospitalization, if they can be treated at a psychiatric urgent care center or crisis stabilization unit, that's more preferable than having a hospital bed. We want to make sure that those resources are utilized. And then after the crisis is over, we want to make sure that those individuals can be treated so that they can remain in their community, and that we lessen the likelihood of another crisis episode. In terms of law enforcement coordination, I think even though that we are an alternative to law enforcement involvement, I think it's incredibly important that we closely coordinate with law enforcement. As you can see, they can be involved in so many different steps of this continuum. In terms of someone to call, we can encourage the public to call 988 or to call our helpline, but in reality, so many people who are experiencing mental behavioral health crisis still call 911. And so we want to work with law enforcement to make sure that if those individuals call 911, is there a way that we can make sure that a mental health response is provided as an alternative to law enforcement involvement? And then in terms of someone to respond, we want to make sure that, when we're responding in the field, in the community, we want to make sure that we have support from law enforcement, and vice versa. When law enforcement is in the community and needs mental health support, we want to make sure that they have access to our resources as well. We need to have good coordination with one another when we both respond in the field. And then making sure that, when there are calls where we, an unarmed civilian mental health team is not appropriate, if there's a threat to public safety, we want to make sure that our co-response teams are involved, and that's teams that are paired mental health clinicians with a law enforcement officer. So there's multiple points along the continuum of care where close coordination with law enforcement is very important. One of the things that we have noticed with our field intervention teams and law enforcement is they often do have some difficulty coordinating in the field. Some examples of this, we've seen that the teams are occasionally unwilling to share complete information about an incident with one another. There's often a lack of understanding of what mental health resources are available and how to access them. Sometimes it's difficult accessing prompt and appropriate support in the field, both on law enforcement's part and on mental health. And then sometimes difficulty understanding law enforcement disengagement policies when law enforcement will walk away from an incident. And then lack of understanding of what mental health capabilities and authorities are to responding to mental health crisis. So these are some of the challenges we've experienced. And about a year and a half ago, almost 2 years ago now, Supervisor Hahn directed the Countywide Criminal Justice Coordinating Committee, the CCJCC, to form a working group to develop best practices for DMH and law enforcement partnerships in support of alternative crisis response. So DMH participated in this working group and brought together representatives of the Sheriff's Department, the LA Police Department, as well as representatives from all of the various police chiefs associations throughout the county, and Dee Dee Hirsch. And so we really wanted to tackle this and examine, where are the areas that we needed to kind of really improve our coordination. The working group identified 4 main areas of focus that they wanted to concentrate on. The first was establishing a framework for the diversion of certain 911 calls to 988. So if an individual calls 911 and a 911 dispatcher thinks this is more appropriate for a mental health response, developing a framework so that those calls can appropriately be transferred over to 988 so that they could be treated in the mental health system. The second piece was developing a set of best practices for law enforcement, how they can obtain mental health support when they're on scene with an individual who's experiencing mental health symptoms. And then developing best practices for our DMH field intervention teams for obtaining law enforcement support on the scene when they need support. And then finally, addressing transportation of clients who are placed on a hold by law enforcement to crisis stabilization units and urgent care centers. So I'm going to just briefly walk through each of these 4 main areas and give you an overview of what we've done. In terms of the 911 to 988 diversion, this is an overview. It's a very simple process. If a call comes in to 911, the 911 dispatcher screens the call, determines that it's appropriate for mental health. They will transfer the call through a warm transfer to 988, and then a 988 crisis counselor will take over the call, and the 911 dispatcher will hang up the line. So the 911 portion of the call is terminated, and 988 officially takes over responsibility for that caller. The system is completely logged, so we're making sure that we're tracking reference numbers between law enforcement and 988. And so in case that there needs to be some kind of follow-up, we do make sure that those things are documented. This is the call criteria generally for 911 dispatchers. We put together a set of a framework that had general criteria, but considering we have so many PSAPs, public safety, 911 dispatch answering points, 45 different police departments in the county, we wanted to make sure that these were fluid and could be adjusted in each jurisdiction. We used the LAPD's protocols as a starting point. They have been, they've implemented 911 to 988 call diversion for several years now. And so that was the framework which we used as a model for developing a framework that could be adopted throughout the county. So generally, we want the 911 dispatchers to identify callers who may be in emotional distress, who are contemplating suicide, any type of mental illness or possible mental illness, or when a third party is concerned about someone with a mental illness. We want to make sure, I think one of the, we leave the transfer criteria very broad, but we want to be very clear about the exceptions, things which we do not feel are appropriate for the 988 system to handle, things that are really present a public safety or medical issue that should remain with 911, and those are over on the right side of the screen, where such as when a caller is threatening to jump from a bridge or structure, if the caller needs medical attention, if a suicide attempt is in progress, or if the caller has weapon and is in public with others present. Once the call is transferred over to 988, the crisis counselor will provide support, risk assessment, safety planning, and de-escalation. If they're unable to resolve the call over the phone, the call will be transferred over to the LA County Helpline to DMH for the deployment of a field intervention team. So this ensures that if somebody calls and does want an in-person response, that's connected to our field teams too. The other situations where if a call is not resolved, if there's a public safety or medical issue that becomes apparent during the call, then 988 will contact law enforcement on a separate line. The crisis counselor will remain on the line until law enforcement or EMS arrives. This is a very small percentage of cases. This is 1 to 2% of calls. But if they identify an issue where there is a public safety threat or medical issue, they want to make sure that they can engage the 911 dispatch center again. I've listed a couple of technology considerations. We're awaiting statewide integration of the 911-988 platforms to facilitate transfer of calls and information between systems. Right now, we're kind of using a manual system while we're waiting for that integration to occur. And using dedicated phone lines for law enforcement so that they're not, calling the same number as the general public, that they can directly get a crisis counselor to support their callers. If anybody has any questions, I'm happy to pause as we go through. I know there's a lot of information I'm presenting. I'm happy to, take questions, so please let me know.
Ruben, I had one question based on
sure.
what you just shared. When do they think that integration is going to happen so that you won't be having to do that manual process to transfer the calls?
It was supposed to happen this year, so we're hoping next year. They're rolling it out in different jurisdictions, and my understanding lately is the latest was there was just some legal documentation issues that they were trying to resolve with at the federal level and state. So it's we're just eagerly awaiting it.
Okay, thank you.
I should note that in terms of this actual process, this is in place throughout the city of Los Angeles in the jurisdiction of the LA Police Department. We've now expanded that to the Sheriff's Department, and we launched at the Lancaster Station in November. And then we also expanded to the Pomona Police Department in December, at the beginning of this month. So, we're now that we've got this framework in place for the county, other law enforcement departments can take a look at this. And if this is something that we want to adopt, D.D. Hirsch is working with them to start to spread this, and eventually, we should have this, implemented across the county.
I had a question, Ruben, and
yes.
Thanks again for this. This is awesome seeing all the progress on this. I'm wondering if it would make sense for JCOD to participate in some way in that work group, at least for awareness that you mentioned, the one you have working group with law enforcement. Obviously, ACR is really focused on Intercept Zero, and you guys are kind of handling that, but whenever you get to a point where it might be an incident where there is an arrest that needs to be made, or there's a risk of an arrest, right, with law enforcement for an individual experiencing this, I think there's a possibility that some of JCOD's programs could come into play at that point. And it might make sense for us to kind of participate in some of those conversations, just to think through what could we do on our end to better facilitate when an individual is moving into more of that Intercept 1-2 on the Intercept model, facilitating access to that individual to our services at that point in partnership with you all. It's just something I'm thinking about that might be a good reason to include like a JCOD team member in that working group.
Okay. The work of the working group tentative, like right now it's ended, but we could restart the working group for different subjects. Right now our objective for the working group was to develop this best practices guide, but it's something that we could easily reconvene. And I think it might be good for us to chat with Mark Delgado from the CCJCC and talk about if there are some other, areas that we want to expand into at this point.
Sounds good.
Okay. So the next piece of this was law enforcement best practices. So ensuring that law enforcement has a clear understanding of what mental health resources exist and how to use them most effectively. There are options for engaging a field intervention team. They can request, we've kind of bucketed this in 3 different areas. They can request, a DMH field intervention team. There's other situations where they will opt to disengage and instead offer the client referrals. And then the third option is law enforcement will request a co-response team. So we've advised law enforcement to consider requesting fit support on scene with individuals who appear to be experiencing a behavioral health crisis. And we've left this, again, very broad. We want to make sure that, if there are anything if law enforcement officers' judgment might benefit from, mental health support, we want to encourage them to reach out to us. But definitely to, reach out to us if they observe an individual who's a danger to themselves or others, or gravely disabled, someone who's articulating suicidal thoughts, or is attempting suicide, someone who's expressing homicidal thoughts or threats of violence or aggression. And then we provided law enforcement in the best practice guide a list of all signs of possible mental illness, just to give them a broad, list of different types of symptoms that might signal that they ought to call for mental health support. We don't want officers to call for a civilian mental health team when there's a crime involved and the officers intend to detain and book the client, if the client is threatening to jump from a bridge or structure, if the client needs medical attention, if a suicide attempt is already in progress, and if the client has a weapon and there are others present, either in public or inside a residence or building. If they do decide to request a field intervention team, we have a priority line for law enforcement for them to contact our dispatch center so that we can dispatch a field intervention team. We've advised law enforcement to offer 9 engagement to the client while they're waiting for an intervention team to arrive. Once the FIT team arrives, they should meet away from the scene to share complete information, and then transfer responsibility to the field intervention team and then leave the scene. In situations where law enforcement needs to disengage, there may be situations where they're called to another incident or they can't remain on scene waiting for a field team. Want to make sure that law enforcement evaluates safety factors, considers the family's preferences if they want the law enforcement to wait with the client while waiting for the field team. If they're going to leave, we'd like them to, law enforcement has largely agreed that they will try to obtain a consent from the client, preferably recorded, and they will consult with the supervisor or area watch commander before leaving the scene. If they do leave, they will offer DMH resources, including our LA County Helpline, 988, and also local psychiatric urgent care centers. I think this last one is very important. If the family has the means to transport the client safely to a local urgent care center, this can be a preferable option than waiting for a field team. And so we want to make sure that those options are presented to the family as well. In other situations, if there is some type of public safety issue, we want to make sure that the law enforcement officers consider requesting one of their co-response teams. And so there are 45 police departments that do have co-response teams associated with them. That is a DMH mental health clinician who's paired with a specially trained patrol officer. And so those teams are going to be critical in those situations where a civilian-only team is not appropriate, where there's some type of public safety threat, like the list that I mentioned earlier. They might also be called if circumstances require a faster response than our field teams can provide. Next, I'm going to go through best practices for our mental health field teams. In the field, if the field team has responded to an individual who's experiencing a behavioral health crisis, usually they are able to resolve those situations on their own. In about 95% of calls, our civilian teams are able to resolve the calls on their own. We request law enforcement support in about 5% of cases. So we've, I know it's a small percent, but it's an important percent, and that's why we want to focus on this and make sure that we've got clear guidance for our field teams when they're considering involving law enforcement. We definitely want our teams to call 911 if a crime is involved, if the client is threatening to jump from a bridge or structure, if they need medical attention, if there's a suicide attempt in progress, and if the client has a weapon in public or in a residence or building with others present. The other situation that arises where our field teams may want law enforcement support is if they have placed a client on a 5150 hold and the client's uncooperative with the hold. And so there are situations like that where the field team feels that law enforcement support would be helpful in gaining compliance from the client with enacting the 5150 hold. So before they do that, before they call law enforcement, we ask our field teams to exhaust the following approaches before calling for law enforcement intervention. We want to make sure that they build rapport with the client, devote sufficient time listening to the client's concerns. Don't make threats, don't use law enforcement as a threat. Actively involve collateral, coach collateral in engaging the client without threats of coercion. And remove distractions. If there's collateral, people around that may be negative, may agitate or trigger the client, we want to make sure that those people leave. So this process can take several hours. I mean, this takes a long time of meeting with the client and talking with them to gain compliance with the hold. But we want to make sure that the clinicians touch on all of these factors before they make the decision that they do want law enforcement support. If they do want law enforcement support, they can request that law enforcement come and issue and provide what we call command presence. And so that is, a situation where our clinicians feel that law enforcement may help keep the peace and offer command presence to gain compliance from the client. And as I mentioned, this is invoked in less than 5% of our field intervention encounters. We note in our best practices guide and for our staff that we are not requesting the use of force to physically enforce the hold. This is a decision that's left up to law enforcement. They may decline to use force if the client does not present imminent danger to others. So we are not the law enforcement generally will not use force to enact a hold absent some kind of imminent danger to the public. If the client still does not comply, our advice for our field teams is to discuss the next steps with law enforcement away from the scene and determine plans to engage the client at a later date or time. This could be several hours later, after the client has had time to come down. It could be the next day, but we want to make sure that law enforcement and mental health have coordinated on a plan to follow up with the client. Our best practices guide outlines, the protocols for establishing communication with law enforcement. This varies across the county. Different jurisdictions have different, preferred ways of getting in touch with law enforcement. Some prefer that we call 911. Some have a dedicated non-emergency line or a mental health unit that we can call directly. And then others just prefer that we call the local station directly. So, this really just takes, it just depends on the And again, with law enforcement away from the client to debrief. We want to make sure that we communicate the risk factors. What are the safety concerns? Why are we placing this person on a hold? Make sure that we've given the officer complete information. Detail all of the different interventions that we've attempted to gain compliance. So we really want to stress to the officers that this is really a last resort. We're calling for law enforcement as a last resort to gain compliance from the client. And then on scene, we need to explain to the client that law enforcement is present only to ensure the public safety. It's not there as a threat, of a criminal, penalty or anything. The other option we wanted to make clear for our clinicians, our field teams, is that you can request law enforcement to stand by nearby if you expect that a negative interaction is going to happen with a client. This can happen particularly if you have a repeat client or someone who's known to have been aggressive in the past. Call law enforcement in advance, arrange for law enforcement to stand at a nearby location. That's much better than calling 911, once things have gone bad and waiting, for that travel time for law enforcement to arrive. So, we want to make sure that our teams know to keep travel time in mind. And, if they anticipate that it could take a long time to get law enforcement there, our law enforcement departments are by and large willing to stand by if they, if we need that support. Third option we've outlined is our field teams have the discretion not to call law enforcement. It's not automatically called for every uncooperative client. We want our clinicians to evaluate the circumstances to determine whether law enforcement presence might be counterproductive. And in consultation with a supervisor, a field team may elect not to pursue the hold and to disengage from the incident. And we've outlined in our guide what are the factors that field teams should consider before disengaging. Make sure that there's collateral family members that are willing to be part of a safety plan. Make sure that there's a follow-up team in place to continue care at a later point in the day or the following day. If the client is not violent, if they're not currently making threats to complete a suicide or homicide, if there's a support system in place to monitor the client, and particularly take note if the family is requesting that law enforcement not be called. These are some of the factors that our team should consider if they're considering disengaging without issuing the hold. As I mentioned, our best practices guide was published to the CCJCC and the Board of Supervisors in October. There's a QR code on the screen if you'd like to have a copy of that. And with that, I'm at the end. I'm happy to take questions.
Does anybody have any other questions for Ruben? Okay, well, we will download this, Ruben, and we'll link it to our website too.
Oh, great.
So people can access it, if they do come to our website, because I think it's a great guide and gives a lot of great information about all of the hard work that your department and all of the collaboration that's been happening in the area. So I really appreciate you taking the time and being here today to share this with the information. And obviously we'll continue to find a way to post this and share it with you, and then also potentially to our YouTube page so people can go back and reference this if they need to.
Great. Well, thank you very much for the opportunity.
Thank you. I had one other announcement that we're going to be changing our public convening schedule moving forward for 2025. So we're going to have our meetings quarterly. The first one will be held in May, first one in February, second one in May, third in August, and the fourth in November. So we're looking forward to seeing everybody in 2025. And with that, I hope you have a great rest of your day. Happy holidays.
Thank you, you too.
Bye-bye, everyone.